at the Department of Mental Health and Substance Use at WHO headquarters in Geneva. Very nice to be here.
Good morning. I'm Annette Verster, and I work at the Department of HIV, Viral Hepatitis and Sexually Transmitted Infections, also at WHO headquarters. And I lead the work on all key populations, which include people who use drugs and people in prisons. Thank you. Good to be here.
Good morning. I'm Jason White. I'm chair of the Expert Committee on Drug Dependence for the WHO, which is the committee that makes recommendations about control of substances under the schedules.
Thank you very much, Zabit. And we also have UNDP joining us online. Boyan, would you like to say a quick introduction?
Good morning, colleagues, and thank you very much for extending the invitation. Good morning from New York. My name is Boyan Konstantinov. I do policy work on key populations, development dimensions of drug policy, as well as on the international human rights and drug policy guidelines. I am with the HIV and Health Group of UNDP.
Fantastic. Thank you very much, Boyan. Thanks for joining us online. And thank you, everyone, for agreeing to be part of this dialogue. We are also expecting to be joined by colleagues from UNAIDS shortly. I think they're stuck in another meeting right now, but they'll join us in a moment. The first question for them isn't until a bit later, so they won't miss anything. As we always do for these dialogues, we put out a call for the questions, so they have been pre-submitted. I see most of you are here in the room. If we have a question from someone that is not able to join us and we can't see them online, I'll just read out the question on their behalf. I hope that's going to be okay with everyone. And just to say a warm welcome to those who are joining us online as well. We can see you on the screens in front of us here, but also behind. So you're very much part of this meeting as well. So, shall we get started? I believe the first question, Sarah, is actually someone who isn't here. Yeah. So allow me to read this one out first. This is for the World Health Organization. And it's from Matare Community Anti-Drugs Coalition in Kenya and IFSW in Austria. How are you addressing the global problem of mental health and ways in which you are pushing governments, the private sector and multinationals to set aside mental health funding, as well as clear guidelines you are putting in place to reduce the cost of treatment and for wider treatment with controlled substances such as ketamine? Thank you very much.
Thank you. And I'll respond to this question. And thank you very much for the question, which put at the focus the issues related to mental health. The COVID-19 pandemic attracted a lot of attention to mental health needs and mental health services worldwide. And WHO continued its advocacy for improving not only coverage and quality of treatment of mental health conditions, but also for improving mental health well-being of people overall, and particularly in emergencies like COVID-19 pandemic. WHO is doing that in collaboration with member states, academia, and civil society organizations. And recently, there were several high-level events organized by the governments of countries in collaboration with WHO, which in fact addressed mental health issues. Last year, the World Health Organization released the World Mental Health Report with subtitle Transforming Mental Health for All. And this is the report which I think would be of interest to read for everybody because it covers many, many issues. It shows how little money is spent on mental health in countries. On average, less than 2% of overall health budgets are spent on mental health. And this is not at all equivalent to the burden that mental health and overall suffering mental health conditions bring to populations. So this is WHO. That was one of the key messages in the report, to allocate more funds, more resources to mental health in the health budgets of countries. When it comes to the medicines, the WHO has been always very attentive to availability of medicines for treatment of mental health conditions, and special activities and programs had been implemented to ensure access for medicines for treatment of epilepsy, for example, but also for other mental health conditions. And we're constantly updating our guidelines on pharmacological treatment. When it comes to ketamine, the question is in the context of treatment for mental health conditions, because ketamine is very important medicine for treatment, for anesthesia, for many other things. But if to speak about the use of ketamine in treatment of mental health conditions, and first of all, depression, we are monitoring the results of the studies, which are interesting, which are promising. But at the same time, the ketamine as a medicine cannot be easily administered in primary health care, for example, or in those settings when you can increase effectively the coverage and quality of treatment interventions for mental health conditions. That is why ketamine for treatment of mental health disorders is not in the focus of our activities, but at the same time, we monitor the situation. We have requests, we have questions about the ketamine in WHO portfolio for treatment of mental health conditions. But again, now I think we still need to accumulate sufficient evidence on the best conditions, on the populations that would benefit most of using ketamine for treatment of mental health conditions. Thank you.
Thank you. Thank you very much. And, okay, so let's move on to the second question. And again, for all the panelists, please do jump in if you want to on any of those answers throughout the day. So the second question is from the International Drug Policy Consortium. Marie, you have the floor. Thanks.
Thank you. Good morning, everyone. So in 2019, the UN task team responsible for the implementation of the UN system common position on drugs contributed to the ministerial segment by producing a landmark report reviewing evidence over the past 10 years of drug policies. As participations and preparations are being made for the midterm review of the ministerial declaration in 2024, how is the UN task team planning to contribute to this important process? And that is a question for all of you. Thank you.
Boyan, do you want to come in on that one first?
Only if the colleague repeats it, because there was a problem with the sound. I couldn't hear you as well in the beginning. Now the microphones are on. Sorry about that. I still can't hear you, Jamie.
Sorry, the question was around how the UN task team is planning to contribute to the midterm review in 2024.
Oh, I see. Thank you very much. It's an interesting question. It would have been good for UNODC colleagues to be in the room. So maybe if there is a special meeting with them, it would be good to ask the same question to them, because they're the chair of the task team. What we're doing at UNDP as member of the task team is that we are obviously insisting that the task team reconvenes and evaluates the work on implementing the UN system common position on drugs, which was rolled out by now, it's 2 years ago. This has to happen soon, and I think UNODC colleagues are working on this. So far, what we see is that the implementation is not sufficient, and it has to happen more, and it has to happen faster. But then again, we don't have all the pieces of the puzzle. So what is of critical importance is for us to gather the information, one. And for the second thing is to find avenues to engage with regional country leadership at the UN teams through the resident coordinators, and in the UNDP case, the resident representatives of UNDP in 170 countries around the world, to make sure that where appropriate, the UN common position is being implemented, and of course that all the supporting materials that the task team shared, including the international human rights and drug policy guidelines, are used to facilitate this implementation.
Thank you, Boyan. Zaved?
Sorry, Zaved, we can't hear you well from the back.
Colleagues, there seems to be a problem with the microphones. I am online and I cannot hear Zaved at all.
That one better? Okay, Zaved. Zaved.
Yeah, maybe this is fine now.
You sure now? Okay.
This is fine now. Yes, exactly.
Swap those now, please.
No, you don't need that. Thank you. I think it is working now. Just, I would like to add a few points which Boyan mentioned, and particularly with regard to UN tax team and how we can contribute to the 2024. Yesterday, High Commissioner made a statement, video message at the CND at the opening. And in that opening, he clearly mentioned that there is a need to engage with the civil society as well as the UN entities in the process. Very much, he would like to see that active involvement of the UN entities in the process. From that perspective also, we do believe from the office perspective, the UN tax team has a role to play. But what role we need to play, we have to discuss in the UN tax team. But if you have any proposal, please put forward to us how we can play a good role in that process. So I would like to pass the ball to you that if you have any specific proposal, what you'd like to see UN tax team is or should do ahead of the 2024 review. In addition to that, I would like to mention one thing, that just this week, last week and this week, Human Rights Council member state, they're negotiating a new resolution on drug policy and human rights. And in the draft resolution, there is a one specific operative paragraph in which Human Rights Council will request the High Commissioner to produce a report on human rights and drug policy ahead of the 2024 review. The way we did ahead of the 2016 August meeting, we produced a report on the global study on the human rights and drug policy. Again, on 2018, we did another report ahead of the ministerial meeting on 2019. All reports was produced to contribute to the debate and discussion during those review process or preparation of the August outcome document ministerial declaration. We hope that this report also will contribute. So from office perspective, we are looking forward to that resolution and to implement that operative paragraph. But as a UN team, UN tax team, again, we need to discuss. And I hope that if you have any brilliant proposal, please put forward to us. We'll take it to the UN tax team and discuss. Thank you.
Thank you so much, Zaved. Thank you. And WHO colleagues, your response.
Well, it's very little to add. I think it's still there is a clear task for the task force to consider what might be the contribution of the task force to the midterm review, but it's not yet defined. So it's still in the process of deliberations. Thank you.
Okay. Thank you very much. So our next question comes from, it's a merged question from Recovering Nepal and from the Middle East and North Africa network of people who use drugs. I believe we have Bishnu online. Bishnu, if you want to unmute and deliver your question. Can you unmute?
Thank you for this opportunity. I would like to ask, for a long time I have been working with a drug field in the country. So I closely, time to time, I work with the VNGOC, but I would like to know is there any plan come up with a regional platform for the VNGOC? So central platform, it's a very big, it's a very actively working, we know, but it would have been better if we come up with the regional platform so that the regional actor we could discuss and forward the key, our opinion, actions in future. Thank you.
Okay, Bishnu, that's not the question we've got in front of us. That's a question for the NGOC, which I'm happy to answer later. The question we have in front of us was the one for WHO, which is how does WHO work to ensure quality assurance in national OST programs and to ensure its rollout in settings such as Pakistan?
Well, there are many multifold activities that WHO is doing I mean all three levels of the organization: headquarters, regional offices, and country offices. Also in collaboration with other UN entities, in collaboration with civil society organizations. And these multiple activities include policy dialogues, advocacy, technical support and normative guidance, research as well. And there are several documents which were released recently. Some of them are directly related to quality of treatment programs, like, for example, practical guide on implementation of specifically agonist maintenance treatment programs in less resource settings that was released last year. The one together with UNODC, the international standards on the treatment of drug use disorders, also together with UNODC. And there is a special activities now on the quality assurance for programs, for treatment programs for drug use disorders, which are also relevant for quality of programs OST. When it comes to Pakistan, there are several high-level missions to Pakistan, which in the focus of which were the issues of provision of treatment. There was a very complex process back and forth in the national implementation. We starting from some years ago, then pilot project, and now I think my colleague Annette will add. So it's definitely on the agenda, high on the agenda. But again, we work with the government to how to make it happen better.
Thank you.
Yeah, thanks. Just in addition to what Vladimir already mentioned, we are working closely with our regional and our country office in Pakistan. And the focus in the last few years has been on the registration of the appropriate medication, because the buprenorphine tablets that were available were very low dosages, and it was very difficult to take the appropriate dose sublingually, because you had to take like 10 tablets under the tongue. So at that clinical guidance level, we are very much engaged. And we're also working at the moment on hiring a consultant at the country office, also together with UNODC, to guide the implementation of OAT in Pakistan. And finally, we're also reviewing all the Global Fund grant, the grant proposals that countries are putting in, and we make sure that harm reduction and OAT are included where there is relevance, which is in most countries, obviously. So also just reviewed the Pakistan grant proposal. Thanks.
Okay, thank you very much, colleagues. And Bishnu, we'll follow up with you separately on your question that you just gave, which is more to the NGOC, but we'll follow up separately on that one. The next question is from ICEAS. Over to you, Maha? Maya, okay, sorry. Over to you, Maya. Thank you.
Thank you. So my question is related to the hierarchy of scientific evidence, and I would like to ask it to the WHO. Current drug policy decisions are generally based on pharmacological and toxicological evidence and focused exclusively on the problematic uses of scheduled substances or their therapeutic or medicinal potential. So is the WHO considering non-biomedical evidence such as anthropological and epidemiological research and studies on non-problematic drug use, including adult recreational use, as equally important in its recommendations and decisions?
Thank you very much, Maya. Thank you. Please.
Yeah, thanks very much for that question. I think the point you make is a very important one. If you look at the conventions, they require WHO to evaluate the extent of public health and social problems associated with use of the drug, and if there is medical use, to weigh those problems against that medical use. So you will find that when there are reports about drugs, they do focus to some extent on the problems, as that is what is required under the conventions. But that doesn't preclude WHO from looking at the full extent of use, and that includes the types of use you're describing, where there may be traditional use, it might be non-problematic use, and so forth. It's often buried somewhat, that information, but I would like to reassure you that that information is considered. We always look at epidemiological evidence where it is available. And that's necessary because we're balancing out information about problematic drug use with the extent of use. We want to know the relative frequency that these problems might occur. That's obviously important. So we need to know something about potential non-problematic use of these substances. So that information is certainly considered, and that's not to say that we couldn't do a better job of it. We can always try and improve on that, but it is considered. And I'll give you the example that kratom was recently reviewed by WHO, and we certainly looked at traditional use of kratom. So we had information in front of us about that traditional use. We also had information about use by people in various countries who are using it for their own therapeutic purposes. So we were very much aware of that kind of use. So that would be an example where we certainly have looked at use in general, not just problematic use. Some of the NPS are also an example where we do look at users' websites. We look at their information about their use of the drug, and we include that information. So there is certainly some attempt to access the type of information you describe and to take that into account in our decision making, but certainly it's something we could improve on and work at.
Okay, thank you very much. Okay, let's turn to the next question on our list, which is from Virginians Against Drug Violence in the USA. Michael, the floor is yours.
Thank you, Jamie. So the question we have is for the Commissioner of Human Rights. It has been stated by member states and more recently by the Commission during these CND meetings that the death penalty for drug use, drug possession, distribution conflicts with the basic tenets of the UN, the Declaration of Human Rights, the UN Charter, etc., even the spirit of the drug control conventions, potentially. How can these principles be better applied and adopted in the CND for drug control?
Thank you very much for your question, Michael. And first of all, I would like to refer High Commissioner's statement yesterday. He called upon all states who used death penalty to abolish it, also for drug-related offenses. So our position is very clear. It is under international human rights law. The state has obligation to stop the use of death penalty for drug-related offenses because it doesn't reach the threshold of most serious crime, which defined as intentional killing. With regard to here, what could be done, that your question particularly, I would like to refer first to the INCB, International Narcotic Control Board. Last few years, since 2012, I believe that first they issued a note verbal to all members, 2012 or 2014, I can't remember exact year, note verbal to all member states who use death penalty for drug-related offenses, calling upon them to stop them. And since then, we have seen systematically INCB in their report addressing this issue. And whenever they are going to a country mission, they are referring to death penalty and raising the concern with the government. That need to continue. I think that it is really good the INCB engage. We welcome that from the INCB. Also, I would like to refer that UNDC former executive director and also different officials, different occasion has addressed this issue and call upon member state to abolish the death penalty. Now, what CND we can do? That it is member states' prerogative. Just we can't say what they should do or not. But obviously, from OHCHR perspective, we'd like to see that more engagement of the CND as a body, the main decision-making body with regard to drug policy making, that one to actively address this issue. For that reason, in our statement to the CND, High Commissioner statement in our different in a different agenda item, we are regularly addressing this issue. We are happy to see that many member states, they are also calling for abolition of death penalty and addressing this issue, and the CND maybe this time to do more, but what they could do more, I think we have to refer and discuss with the member state. But our position very clear. Thank you.
Thank you very much, Sabit. And just a quick word, just to welcome Christine Stegling to the panel as well. Christine, you're only here for a day and a half at CND, so I appreciate you fitting us in. It's been obviously a busy schedule for you. Christine is the Deputy Executive Director of UNAIDS. So very much welcome to the panel. We've got questions, as you see, in front of you, but please do feel free to come in on someone else's answer if you have anything to add, of course. So the next question we'll move on to is a joint one from Youth Rise and Students for Sensible Drug Policy. Do we have Ruby or Ellie in the room? Right at the back. Hey, so over to you. Thank you.
Thank you. Yeah, I'm representing Students for Sensible Drug Policy and Youth Rise today, and our question for the World Health Organization is: stigma and discrimination are factors which deeply affect the lives of key populations, especially young people, and can be significant barriers for access to healthcare. How is the World Health Organization planning to engage with the reduction of stigma revolving around substance use and the needs of young people, including young sex workers who use drugs, particularly in environments where drug use is addressed as a criminal matter rather than a health issue?
Thank you.
Thank you very much for that question. You may be aware that in 2014, WHO issued guidelines on key populations where stigma and discrimination and decriminalization recommendations were made. And we updated these guidelines last year and published them in 2022. And again, we have these important recommendations that besides talking about health interventions, it's critical to address the structural barriers first, because otherwise people can't attend or access the health interventions. So stigma and discrimination, absolutely critical. Criminalization of behaviors. So we have this recommendation that says that countries should work towards the decriminalization of behaviors, including the drug use and possession for personal use. So that's been out there since 2014. But of course, these guidelines need to be disseminated, which we do, and we use all the occasions to advocate for this. And actually, tomorrow we have a side event, a WHO side event, where we will also address this in more detail. We met with Youth Rise and youth organizations during the development of these guidelines. I don't know if it was you who was engaged in this, but as part of the group that is, it was a subgroup of the interagency working group on key populations. So we addressed a lot of the things, and you were able to review the guidance before they came out. Unfortunately, of course, we can only look at the evidence, make recommendations, and advocate for them. And then at the end of the day, it's up to countries what they do as life goes. And I just wanted to add that we also started a recent new project around stigma and discrimination across the whole WHO. So it's not just related to HIV or drug use or hepatitis, but it's across the organization. And we hope, and it's about stigma and discrimination in the health sector, particularly. And we hope to come out with a training that will be accredited and potentially part of the WHO academy that's based in Lyon. So we're working on this, but we look forward to your engagement and involvement in further work on that. Thanks.
Thank you, Annette. Please,
Just few additional words, and this is about stigma and discrimination in health services, because this is one of the key barriers for provision of effective care. And the major attention should be given also to addressing stigma in the attitudes of health professionals and service providers. And personal stories and direct interaction with people with lived experiences was shown to be one of the most effective strategies based on all the literature and reviews that we have on effectiveness of different approaches. So that's something that we consistently trying to do. And I think, as Annette mentioned, this is multiple activities in WHO on that. Thank you.
Thank you so much, colleagues. Boyan, I apologize. I didn't see you had your hand raised. Was it around the stigma question, or do you want to go back to the previous question? The floor is yours.
Thank you very much. No, it's actually around key populations. So it is connected to some extent also to stigma and discrimination. I just wanted to add that I was very impressed when the consolidated guidelines of WHO were being discussed, that there was quite a lot of involvement of young voices, which is really something that I found personally very gratifying, and I'm very grateful to WHO colleagues for engaging in such a way. And to add that UNDP is partnering with UNICEF. It's a UNICEF-led initiative in partnership with UNDP, UNFPA, the UNAIDS Secretariat, and also in consultation with WHO on an adolescent and young key population toolkit, which is trying to combine and update global information on interventions that benefit young key populations, and resources that are developing with the actually active participation of young key populations, including to the network of young champions that we're trying to support. I'm going to share information about the toolkit, and there were some side events on these initiatives in Montreal last year. And I would like to say that indeed, the discourse around legal and structural barriers when it comes to the meaningful engagement and the design of packages that are acceptable to young key populations is something very important and a priority for UNDP, including in terms of follow-up with the recommendations of the Global Commission on HIV and the law. So feel free to reach out to us when it comes to opportunities for partnership, or when it comes to specific challenges in regions, particularly related to legal and structural barriers. And I'm also going to share a report for submission around these issues, as well as community engagement in the UNDP PEPFAR partnership scale. Right now, you have the opportunity to actually submit your concerns and good practices of what is being done, and it will be reviewed by us in the process of this partnership project, which focuses on the 10-10-10 indicators. Thank you very much.
Thank you, Boyan. And Zabed, you wanted to say a few words?
Thank you very much, Luisa and Ruby, for your question. Yes, I would like to add something from the human rights perspective, that the stigma and discrimination, one of the key causes that criminalization of drug use, criminalization of sex workers, criminalization of LGBT population, and all this criminalization is creating the serious human rights violation in many parts of the world. So we need to address that criminalization issue. In this regard, I would like to refer, and High Commissioner also called for decriminalization for possession of personal use and possession of drugs. In this regard, I would like to refer, most recently, just last week published, 8th March principle on Crimes and Human Rights, Criminal Law and Human Rights, which was developed by the International Commission of Jurists with the support of UNAIDS, WHO, UNDP, I think UNDP, not WHO, UNDP and OHCHR. And in this 8th March principle, we have identified that jurists, they have identified various category of acts which should not be criminal, including the drug possession, use, and this aspect in the principle, as well as sex worker, decriminalization of sex worker, decriminalization of same-sex conducts, decriminalization of reproductive rights related issues. So I would like to request Students for Sensible Drug Policy and also Youth Rights and others colleagues to look at that 8th March principle. If you Google it, immediately it will come up. It is published by the Commission of Jurists, International Commission of Jurists. I think it is really important new document. We can look at it. Thank you.
Thank you very much. Okay, we'll move on to the next question, which is from Cadco in USA and also Mavendi International. Esbjorn, the floor. Oh, sorry, is Sue here or someone from CADCA?
No, this is General Barry Price from CADCA.
Oh, sorry. Hey,
Thank you. No problem.
you have the floor. Thank you.
Yeah, I'm a little taller than Sue. So my question is for the WHO. Substance use prevention is a sound investment, with every dollar invested having the potential to result in savings of between $2 and $20. However, it has been underutilized and under-resourced. How will WHO work together with UNODC and other agencies to strengthen the prevention work and make it a higher priority?
Thank you.
Thank you very much for this question. And indeed, substance use prevention is the best and most cost-effective approach when it comes to health consequences of substance use. But we need to have the right balance between different prevention strategies and approaches: primary, secondary, tertiary, universal, indicated. I would like to highlight several issues which are particularly important for us. Is elimination of any marketing and advertising towards young people regarding all substances, nicotine, alcohol, drugs, and avoid any communication that can increase attractiveness of substance use for young people. The second point that I would like to make is the commercial influences. And which become, we know these commercial influences on tobacco, we know it very well on alcohol, and recently we have new developments which make the prevention activities challenging, and particularly when it comes to marketing. And finally, digital issues, social influences and their role in communication which targeting underage people, children and adolescents, which is critically important for protecting their health. Indeed, prevention is not very well addressed in activities of the UN system. And for this reason, with UNODC, we created the interagency technical working group on drug demand reduction, on prevention and treatment of drug use disorders, and we are trying to address it in collaboration with other UN entities. And you know that we have international standards on prevention. There are several other activities which are dealing with again, children and adolescents. In WHO, we have special programs because prevention of substance use is not only, it cannot be considered in isolation. It's linked to mental health, it links to overall health, and there are a lot of activities which address both protective and resilience factors and risk factors in children and adolescents. Thank you.
Thank you, Vladimir. Okay, we'll move on to the next question, which is from the Eurasian Harm Reduction Association. And this is a question for all of our panelists across the agencies. Gunnar, you have the floor. Gunnar?
I'm sorry, I'm in a different context. And our question was for the Human Rights Office, and actually for the ways how to overcome the stigmatization and criminalization, and what are the plans for your activities?
The question we've got here is about the Ukrainian population in prisons.
Yes, and the context of it, also the Ukrainian population imprisoned in the occupied territories. They are moved to Russia, and they have no access to OHCHR, and international agencies have the challenges to approach them, as well as NGOs.
Okay.
And that's actually the details.
Thank you, Gana. Thank you. So let's take that. Can we take that from left to right on the panel? Maybe Christine, if you want to go first on that one, and then Zaved, or no, Zaved, you start.
Okay, if I understood well about your questions, that already I respond that decriminalization and all this thing. Here, the question which we have with regard to Ukraine situation is a complicated situation. You're just mentioning that Ukrainian population in the territory occupied by Russia, and their access to AIDS, TB, and other health services. Gana, just one thing I would like to mention, we have UNAIDS colleagues and WHO colleagues, they are in a better position to respond that one. But from human rights perspective, I would like to mention that we need more information to react on that, very clear information. And also Human Rights Council has established a commission of inquiry for Ukraine. This is ongoing commission of inquiry. I would recommend that from partners and colleagues from Ukraine and your organization to present evidence to them to look at this issue. Maybe they will be interested, because they are also looking at not only civil and political rights issue, extrajudicial killing and others, torture and other issues. Also, they're looking at economic, social, cultural rights issue, which include health aspect as well. So I would recommend to bring that to their attention. Thank you.
Thank you very much.
Caught my breath.
Yes, okay. Thanks.
Sorry,
Thanks.
I was looking at the question that I'm supposed to answer in a minute.
Yeah.
Thank you very much, and thank you, Anna. It's a complex situation, as we all know. I think from our perspective as UNAIDS, the country office is really engaged and is trying, the UNAIDS country office is really engaged and is trying the best it can to work with partners on the ground. And I think importantly, what we have seen the last 12, 13 months, one of the important partners in this, creating access and ensuring that people have access to services, work with civil society. And that has happened. I was previously involved in that in my previous role before I became part of UNAIDS, but I know that the country office is also supporting that. I think we need to be really creative. It's a really complex set of issues to work through. And from our perspective, I think one of the substantial partners in there is also not just to work through humanitarian agencies, but to work in collaboration with civil society, who have been able to work in creative ways to describe, to find a way of saying that. But I think there's a lot more to be done, and I think the situation is changing because it's becoming a much more long-term situation now, and therefore I think our response will have to change as well. So I don't have all the answers, but all I'm saying is that we're literally in contact with our Ukraine office every day to discuss possibilities of how to do that better.
Okay, thank you, Christine. And WHO colleagues, anything to add on that?
Yeah, thanks, Gana, and thanks for being here. It's very similar to what Christine said. We work with our country and regional office, but very complex situation, especially around people in the occupied territories. What we have been focusing on was also more the short-term continuation of ARVs for people living with HIV and OAT for people on OAT, and now also supporting the introduction of long-acting buprenorphine together with Vladimir's team. So, but hugely complex and more needs to be done there. Thank you.
Thank you very much. Okay, We have 10 minutes left, so we're going to try and get through as many questions as we can, but just warning you now, we are not going to get through this whole list, and I apologise in advance for that. We will work with our colleagues on the panel here to make sure any other questions submitted are answered in writing, because I know as well you guys have put a lot of effort in to actually prepare your answers to these questions as well. So apologies for that, but let's keep going. So the next question is from Veterans Action Council. Nate, the floor is yours. Oh, it's Etienne online. Oh, I do apologise again. Okay, Etienne, please take the floor. If you can unmute, that's it. Thank you.
Yes, thank you. Veterans Action Council of the United States. My name is Etienne Fontaine. Thank you, Jamie, and all attendees. For the WHO, how has the discovery of the endogenous cannabinoid system in the 1990s affected your work, given that it serves a critical modulating function in all mammals?
Thank you for the question. There certainly has been a lot of research over the last 20 or 30 years into the endogenous cannabinoid system. And I think it's had a couple of different influences. One is we better understand the different functions that the cannabinoid system can have, both in the brain and outside the brain, such as the effects on immune function. So that gives some better understanding of the actions of cannabinoid drugs, which includes their therapeutic actions and potential therapeutic actions, but also their potential adverse effects as well. The other thing is that this research has led to a better understanding of the action of cannabis, particularly THC compared to a lot of the synthetic cannabinoids. So we understand much better now that in terms of the endocannabinoid system, THC is a relatively weak compound and doesn't produce the effects that you see with a lot of synthetic cannabinoids. So the differences in the pharmacology of THC compared to the newer synthetic compounds has also been a result of better understanding of that endocannabinoid system.
Thank you very much. So the next question we have is another combined question from Peace and Hope for Youth Development and Slum Child Foundation. George, I can see you're with us online. Is Augustine here in the room? No, George, do you want to, can you field the question, or would you like me to read it out from here? It's up to you. Hi, George.
Hi, good morning. Okay, good morning from New York. It's pretty very early here, so I'll just go straight to my question. I know it goes to WHO, but it might cut across to the people in the room. The question is, a lot of young people have been affected by drug abuse. How are you collaborating with the civil society organization at the grassroots level to assist young people, including to clear the air about the cannabis vote that took place here in Vienna and what it really means? Because a lot of young people took it as if the UN legalized marijuana. So please kindly take the floor. Thank you.
Thank you, George. Thank you very much. Over to you.
Yes, unfortunately, there's been a lot of misunderstanding about the changes that occurred as a result of the vote on cannabis. So the only change that occurred was that cannabis has been removed from Schedule 4. Now, Schedule 4 means that countries are encouraged to have relatively strict regulations, stricter than they would normally have for a substance in Schedule 1. So in terms of international controls, there actually is no change that has occurred as a result of the vote of the CND. However, I think the change has also been to indicate that cannabis is not so dangerous a substance that it can never be used in medical practice, which was some of the guideline that was discussed in the commentaries to the convention originally. We're aware that there are some different understandings of what occurred. And it is very difficult to counter those, but certainly WHO has made every effort to try and clarify exactly what occurred and what the implications of that are at every opportunity.
And of course, the collaboration with civil society organizations and young people, and again with the UNODC, we had this youth forum. We have a youth forum now for mental health, and these issues raised in these conversations and these dialogues. So we really consider that as critically important to involve people of young age in any activities which are supposed to target or to have an action on young people, including people with lived experience. Thank you.
Thank you very much. So let's quickly try and squeeze in another question before we have to go. So we have Tatiana online from Schoon in Lebanon. Tatiana, the floor is yours. Thank you.
Thank you, Jamie, and hello, everyone. So hello, and our question is addressed to the UNAIDS, representative from the UNAIDS, and I'm speaking on behalf of Schoon, which is a harm reduction center in Lebanon, but also raising a concern by several harm reduction organizations working in the region. So basically, we would like to have a bit more clarifications on the informal reports that we've been hearing on the potential closure of the UNAIDS MENA office. And if accurate, if this information is accurate, the reasons behind it, and given the implications also that this would have on programming and response in the region, HIV response in the region. Thank you.
Thank you very much. Christine.
Yes, thank you. And thank you for your question. Yes, indeed, this is correct. UNAIDS decided earlier in the year to close the regional office in Egypt. We still have, and we will maintain and possibly strengthen our presence in 5 countries in the region. We have presence in Algeria, Morocco, Tunisia, Egypt, and Sudan. We have arranged for the Francophone countries to be working with the regional office in Dakar, and the Anglophone countries to work with our regional office in Johannesburg. I want to emphasize that, you know, this is not an easy decision to be made. It is a cost-saving decision that UNAIDS had to make. But we are really committed, and I have had several conversations since last week with representatives of civil society, even here at CND, but also last week with the MENA-H Coalition, to explain that really behind this, there is nothing that says we are not committed to the region. We are really committed to the region. We will do the best we can to continue the work that we are doing. I have also challenged civil society to tell us at UNAIDS what they will lose with the closure of the regional program and what creative solutions might be to fill whatever it is that might not be we might not be able to do in the same way without a regional office. UNAIDS is a joint program of 11 UN agencies, the only one in the United Nations. And I think one of the ideas that we really need to tap into is how we can make use of that joint program and the fact that we are a program of 11 UN agencies. I'm in a situation where financial constraints have meant that we would have to close the regional office. We're really open to discussions. Please do come to us, speak to us. We are winding down the office by June this year. There is people who are in charge of that, and there is a transition plan. So please do speak to us. I think one last thing to say, Jamie, because I joined late. I did have a separate meeting with a part of civil society yesterday. So it's not that I didn't want to talk to civil society. I just also wanted to confirm UNAIDS is really committed to this work, and that is why I'm at CND this week. We know that 70% of new infections are in key populations, and drug user populations are obviously part of that. We are very for us, prevention in particular and harm reduction is a good part of prevention, and other drug user interventions are part of that prevention, is a big priority for us and a big priority this year. So yeah, I could say more, and I could have said more if I came earlier, but please be reassured that not only is this a big issue for us, but also working in collaboration with civil society is and will always be a big part of what UNAIDS does.
Thank you so much, Christine. That's great. Okay, let's turn now to the next question from the Turkish Green Crescent Society. I believe we have Handa in the room. Oh, yeah, there you are. Hi, thank you. Floor's yours.
Our question goes to OHCHR. In some parts of America and Europe continents, the legalization and decriminalization trends in cannabis policies have initiated a phase of the liberalization and other psychoactive drugs in the levels of personal use and possession. As OHCHR, do you think these kind of limited freedoms should be analyzed in the concept of public health of the communities or individual freedom only? Thank you.
Thank you, Eugene, for your question. And first, I would like to highlight that what is our office position with regard to criminalization. This morning, I was in one event organized by Norway and civil society organization. I was discussing about the decriminalization. Our office position, decriminalization of personal use and possession of drugs for all type of drugs. We are not making that distinction, the cannabis or non-cannabis and others. So, however, we do realize that different country has different priority and they would like to go step by step process. So that is also welcoming that maybe strategically that can, but from human rights perspective, it is very clear, not from the office, also human rights treaty body. I was giving the list of the treaty body. 5 treaty bodies has addressed this issue and call for decriminalization. Also, a special rapporteur on the right to health, from right to health perspective, also put forward that argument, the decriminalization of all crimes. So that is our office position, and I would like to give forward to the maybe WHO colleague from public health perspective, what should be the discourse on that. That much I could say on this point.
Yeah. Well, in WHO, we have been always promoting public health approach to drug issues, to drug use and drug use disorders, and consider them as health conditions. So I think that has been always a position of WHO, and that we support. Okay, thank you.
Thank you very much. Okay, we've just gone over time. We've got just over halfway through the list of questions. So I know I can see some of you in the room who also submitted questions. So I apologize we weren't able to go through them all. As I say, we will follow up with our wonderful colleagues here from the agencies to get you a response to those questions as well. Thank you everyone for coming, and a huge thank you to our colleagues from UNODC, UNAIDS and OHCHR, and Boyan from UNDP online as well. Thank you everyone. We're going to have a time.